So I had this lecture prepared quite a long time ago, and I've been meaning to record it, though I hadn't had the time to go around to do it. But someone mentioned that I don't really have much surgery content on my channel. So I decided, let's do a video on cholecystitis. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. There's a series on my YouTube channel where we look at medical topics in depth. Today we're going to look at cholecystitis. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications of such amazing content every time I post. Drop a like, drop a comment to show some support. Here's our warm-up question, which is an essay. A 34-year-old woman presents with mild yellowness of the eyes, pain in the right hypochondrium, and fever. She gives history of previous episodes which resolve on antibiotic treatment. Answer the following questions. What is the most likely diagnosis? What is the most likely cause? What other two things would you ask for in the history? What two blood investigations would you ask for? What two signs would be present on abdominal examination? What radiological investigation is indicated? You may pause the video, write down your answers, scream it at your screen, and let's go with the lecture. So remember, in medicine, anything that ends in itis means inflammation. When you talk about mastitis, inflammation of the breast. When you talk about appendicitis, inflammation of the appendix. So when you talk about cholecystitis, this is just simply put inflammation of the gallbladder wall. It can be divided into two types. You have an acute type of cholecystitis, which has a sudden onset, and a chronic type of cholecystitis, which has a prolonged, gradual, remitting, and prolonged episodes. With the acute cholecystitis, it may be associated with gallstones, what we call acute calculus cholecystitis, or it may not be associated with gallstones, what we refer to as acute acalculous cholecystitis. So we'll begin by talking about acute calculus cholecystitis, the one that's associated with gallstones. So remember, again, this is inflammation of the gallbladder wall. It's going to be occurring in a patient that has pre-existing chronic cholecystitis. However, it can also occur as a first presentation. And like I said, it's going to be associated with gallstones, so it's going to be due to an impacted gallstone in Hartmann's pouch obstructing the cystic duct. So some bacteria that may result in this type of cholecystitis include E. coli being the most common organism, Klebsiella, Pseudomonas, Proteus, Salmonella, Streptococcus faecalis, as well as Clostridium welchii. And remember that the infection could either be arising as through hematogenic spread from the hepatic artery as well as the cystic artery spread, so it's through blood. It could be through the portal vein. It could also be through the bowel after filtering in the liver via the portal circulation. Remember that the stone that are going to be causing obstruction in the Hartmann's pouch or in the cystic duct are going to precipitate stasis of the contents on the inside. Eventually, there's going to be edema of the wall. There may be bacterial infection and bacterial overgrowth, and the various effects are going to be seen in acute cholecystitis. The impacted stone may also cause mucosal erosions, allowing the bowel salts to actually act over the submucosal tissue, as the bowel is actually toxic to these tissues, and it may lead to necrosis and further infection, and often it may even lead to perforation of the gallbladder, usually at Hartmann's pouch. Remember that when we actually look at a gallbladder that has acute cholecystitis, generally the gallbladder is going to be distended, there are going to be edematous friable walls, and the walls are going to be containing dilated vessels. There are going to be these areas of necrosis, because inflammation sometimes does come with necrosis, and there's going to be some patchy gangrene in severe cases. The mucosa may show some ulcerations and necrosis, and of course the lumen is going to be containing infection fluid, infected bowel, and sometimes even frank pus. When you actually look at it under the microscope, you might see some acute inflammation, which is going to be marked by neutrophils and edema. You're going to also have areas of necrosis and cell death. What are some of the clinical features that we often see with acute calculus type of cholecystitis? So you get the sudden pain in the right hypochondrium region. There's going to be some tenderness, guarding, and rigidity. It's usually for more than 3 hours, and the pain tends to radiate to the right scapula. Remember, when you're going to do the abdominal examination, you may get a palpable, tender, smooth, soft gallbladder, and you may get a Murphy sign. So remember, Murphy sign is just simply pain on deep inspiration that's going to be resulting in inspiratory arrest. As you're trying to palpate for the gallbladder and you ask the person to breathe in and take a deep breath, remember that the diaphragm will push the liver and it will attempt to push the gallbladder downwards, and once it comes into contact with your arm, it's going to cause the person to hold their breath because they'll be in pain. This is often positive in 1/3 of the patients. You may sometimes get a sonographic Murphy sign, where you get pain on the right upper quadrant when you place the ultrasound probe in that area. This has an 87% sensitivity. You may get areas of hyperesthesia between the 9th and the 11th rib. On the right, you call this as Boas sign. You may get features of jaundice and sometimes some non-specific features such as fever, nausea, vomiting, and anorexia. There may be a palpable tender mass in the gallbladder region in 25% of the cases. You may sometimes get tachycardia, some toxic features. Ileus, you may get some mild abdominal distension in very severe cases. Now, what investigations are we going to do to make a diagnosis? You may get this diagnostic investigation such as imaging. An ultrasound is very important to make a diagnosis. So this is actually going to be revealing that there's going to be either the presence or absence of gallstones. You may get cholecystic fluid. You may get thickening of the gallbladder wall greater than 4 millimeters. And of course, the ultrasound will show a dilation of the common bile duct if the stone has been passed. Then you also want to get a plain x-ray, and in about 10% of the gallstones, as you already know, are radiopaque. So you may actually see them on the x-ray. And then this also rules out other causes of acute abdominal pain, such as a duodenal perforation, where you're going to see air under the diaphragm. In some cases, depending on how you're taking the x-ray, but most commonly you're going to see this on the chest x-ray. You may also see a gas shadow that's seen in the region of the gallbladder, which is going to be emphasizing that there's some emphysematous gallbladder, which is kind of like an emergency. And you may sometimes see a porcelain gallbladder that may be seen as an opacified area in the gallbladder region. You may sometimes do a HIDA scan, which is the most sensitive, where there's going to be non-filling of the gallbladder, even when the small ball is visualized, and this is very characteristic of an acute cholecystitis. So here is a picture that's going to be visualizing these multiple gallstones. As you can see, these whitish deposits inside there, these are the gallstones. And then this is ultrasound showing a roundworm. As you can see, here's a roundworm. This is the outline of the gallbladder. You have the roundworm in the gallbladder. Then this is what a HIDA scan actually looks like. And on the left side here, this is going to be demonstrating the uptake of the contrast into the intrahepatic duct and the gallbladder at 20 minutes. As you can see on this picture here that says 20 minutes, and the excretion into the bowel here at 30 minutes. Then on the right here of this image, that's where the gallbladder is not actually visualized. Even after 4 hours, you can't even visualize the gallbladder. And generally, though the small bowel can be visualized, this is usually consistent with a cholecystitis. Again, here is a scan. This must be a CT scan. As you can see here, you have your gallbladder over there, and here you have your stone that is there, most likely in the cystic duct. You may also order for some supportive investigations such as blood, a full blood count that may show leukocytosis with predominant neutrophilia greater than 10,000. Then you may also see liver enzymes that may be elevated, and you may do this to actually check the damage to the liver. You may also get an increase in alkaline phosphatase. Remember, whenever there's a biliary pathology, this enzyme tends to increase. The serum amylase may be increased, but below the diagnostic threshold for the one that we know for acute pancreatitis. You may also get some total bilirubin being increased. You also want to get your urea, creatinine, and electrolytes. A differential diagnosis includes duodenal ulcer perforation, acute pancreatitis, retrocecal acute appendicitis, right-sided acute pyelonephritis, lobar pneumonia, myocardial infarction, a ruptured ectopic pregnancy, of course in females, and viral hepatitis. Now, how do we manage these patients? So generally, you want to admit the patient, and the initial management is actually conservative in 95% of the patients. So you want to push in an NG tube to aspirate anything that may be in the stomach if they are showing even features of intestinal obstruction. You want to give them some IV fluids, analgesia, and some antispasmodics are good. Cover them on some broad-spectrum antibiotics, especially the third-generation cephalosporins. But what I've noticed is that most organisms are actually becoming resistant to even the third-generation cephalosporins, and this calls for need to actually escalate the types of antibiotics that we use. So we can actually use any of these antibiotics that are listed here on your screen. Of course, admit them for some observation and do follow-up ultrasounds. Later, after 3 to 6 weeks after you have treated the acute infection, you can actually remove the gallbladder via an elective type of procedure that's known as a cholecystectomy. This can be done either through the open method, or you use a right subcostal or cautious incision, or through a laparoscopic method. Remember that cholecystectomy is done immediately in patients that have the following things. Number 1, empyema of the gallbladder. If there is pus in the gallbladder, you get it removed immediately. Number 2, if there are persisting symptoms, you get it removed. If there are progressive symptoms, you also get it removed. And remember that during a cholecystectomy, the gallbladder is going to be opened and all the stones and the pus are going to be removed. And either a Foley's or a Malakot's catheter is going to be placed in the gallbladder and is going to be exteriorized. Then after 3 weeks, the elective cystectomy can actually be done. So indications for cholecystectomy or emergency cholecystectomy, which is in about 5% of the patients, is going to be those that present with empyema gallbladder, those that have persistent symptoms, or they fail to respond to medical therapy, those with emphysematous cholecystitis, those with perforation or peritonitis, and even the elderly. Then here's a picture of a Foley's catheter that is placed in a severely ill patient with acute cholecystitis, and it's meant to drain the pus, and then later on you can perform your elective cholecystectomy. Remember that this procedure is done in the elderly, it's done in those that are severely ill, those that have empyema gallbladder or emphysematous gallbladder, and those that have a perforation of the gallbladder before you actually go and do the cholecystectomy. Complications include perforation. This often occurs in the fundus or in the neck, the Hartmann's area, and it can cause cholecystoduodenal, sometimes a cholecystointestinal, sometimes a cholecystobiliary fistula. You may get a peritonitis, you may get a pericholecystic abscess, you may get a cholangitis, a septicemia, you may get empyema gallbladder, and you may sometimes get gangrenous gallbladder. Now I want to take a bit of some time to explain a little bit about empyema gallbladder. Remember that this is when you have pus that is filling up in the gallbladder. This is a type of acute cholecystitis that actually carries a very high mortality rate. In about 30% of the cases, the pus may be sterile, and it also occurs in a pre-existing mucosa of the gallbladder where it actually gets infected. It's much more common when you get an impacted stone in individuals that are diabetic and those that are immunosuppressed. In our case, HIV being the most common, and in those that have long-term use of corticosteroids or steroid therapy. And remember here, the gallbladder can perforate, it can form an abscess, it can also form a peritonitis, which is going to be due to biliary and as well as bacterial causes. And clinical features are going to be a patient that's looking very toxic. They may have fever, they may have pain and tenderness in the right hypochondrium, they may have a tender, smooth, globular gallbladder that is palpable in the right hypochondrium and to the right of the right rectus muscle. And investigations that you want to do include an ultrasound, a full blood count that may show a rise in the white blood cell count. You may also do a radioisotope scan. A high-dose scan can also be done. Then treatment includes covering them on antibiotics, our third-generation cephalosporins like cefotaxime. You may also add quinolones, ceftriaxone, perform an emergency cholecystectomy. Often initially the cholecystectomy is done either with the Foley's or the Malakot's catheter that's kept in situ for about 3 to 6 weeks. Then afterwards you perform a cholecystectomy. Complications include septicemia, rupture, and even peritonitis. Now we move on to acute acalculous cholecystitis. Remember that here you don't have any evidence of a gallstone, and this is actually thought to be due to biliary stasis. So it's actually quite uncommon entity. In about 5 to 10% of the patients present with this, and it's often commonly missed. So risk factors include patients that are in ICU because there is this bowel stasis, and with this multiple organ failure, it's seen with trauma patients, especially those that are after major surgery, patients with burns, sepsis, those that are on total parenteral nutrition, or any other cause of stress, or in the case of any other causes of the cholecystosis. Then remember that the exact cause of this is not really known, but the gallbladder is going to be distended. There's going to be release of activation factor 7 that may be the cause and has been postulated by many clinicians. And the pathology is there's going to be some edema, there's going to be some necrosis of the gallbladder wall with features of acute inflammation. The presentation is usually acute, and it's quite similar to the acalculous type. The clinical features are similar. So you want to get an isotope scan, a HIDA scan, to confirm your diagnosis. When you do an ultrasound of the abdomen, there may be biliary sludge and inflammation that may be seen, and complications such as gangrene, empyema, perforation of the gallbladder can be seen. When you do your labs, you may get a leukocytosis with an increase in the alkaline phosphatase, as well as LFTs, amylase, and total bilirubin may be increased. Treatment is, of course, an urgent cholecystectomy that may be done by the open method, or it may be done laparoscopically with a small incision, a keyhole incision that's usually placed, can be placed just underneath the umbilicus, sometimes as a subxiphoid, depending on the technique that's going to be used. Then, of course, percutaneous ultrasound guided, or even CT guided, or even an open cholecystectomy is initially done. Then later on, you perform a cholecystectomy as a treatment. Cholecystotomy, rather, then you perform a cholecystectomy as the treatment. Then sometimes you may get safe dissection of the Carlot's triangle, which is actually key when you're performing the procedure. And if the whole gallbladder cannot be safely removed by partial cholecystectomy, or rather, if the whole gallbladder cannot be removed, then the partial cholecystectomy can actually be done. Then I want us to also talk about emphysematous cholecystitis. This is very commonly seen in elderly patients. It's seen in diabetic patients. It's also seen in patients that are immunosuppressed. The causative agent is Clostridium welchi, and here that's where you get gas in the gallbladder. This is actually can result in a life-threatening type of septicemia, and it's considered as an emergency. It may cause severe fulminant cholecystitis, gangrene, perforation, or peritonitis, and so an emergency cholecystectomy is actually needed. The absence of stones is observed in more than 50% of the cases. And then here again is an ultrasound that's going to be demonstrating air, as you can see, within the gallbladder. So this is going to be characteristic of emphysematous gallbladder. Then lastly, I want us to talk about chronic cholecystitis. Remember, this is a chronic inflammation and there's thickening of the gallbladder, and the gallbladder is non-functional and non-distended. Causes include gallstones. You may have chronic acalculous cholecystitis. You may have cholecystosis. And then organisms that are associated include Klebsiella, Streptococci, and Salmonella. Remember that the cholecystosis are these chronic inflammatory conditions of the gallbladder that are going to be associated with cholesterol deposits. They are going to be due to this defective transport of the absorbed cholesterol, which accumulates in the mucosa, and there is also increased absorption of cholesterol by the gallbladder epithelium. Remember that this cholecystosis gallbladder is actually more prone to infection, and it may precipitate stones forming, and it may sometimes be pre-malignant. There are predominantly 5 types. Type 1 through up to type 5. Type 1 is where you have aggregations of cholesterol crystals in the mucosa and submucosal. We call this as a strawberry gallbladder. You may have some lipid contents that are present in large foamy cells, which have been phagocytosed, which have phagocytosed cholesterol. And here the cystic duct appears normal, and the disease only occurs in the gallbladder. This is considered as a pre-malignant condition. Then type 2 is you have this cholesterol-laden polyploid projections in the mucosa. So you have this gallbladder polyps. Then type 3 is where you have this granulomatous thickening and hyperplasia of the gallbladder wall. You may have this cholecystitis glandularis proliferans. Then you have type 4, which is the diverticula that are forming in the wall of the gallbladder. This is a diverticulosis of the gallbladder. Then type 5 is the gallbladder wall fistula. Clinical features include features that are going to be like we saw with calculus cholecystitis, like dyspepsia. You may get a positive Murphy sign. And of course, investigations include an ultrasound of the abdomen, and you may also order for the isotope scans. The treatment is, of course, a cholecystectomy. This should always be done, whether they are symptomatic or not, because of the potential risk of it becoming malignant. In the pathology of chronic cholecystitis, remember the gallbladder is going to be shrunken, it may be contracted, small, and non-functional, and there may be some fibrotic thickened wall, and then you may also have mucosal proliferation into the lumen that's creating these deep clefts into the wall, projecting into the muscular wall of the gallbladder and being lined by epithelium. You call this as Rokitansky-Ashkoff sinuses. Then you may also get this muscular wall that is atrophied and is often replaced by this fibrous tissue. Clinical features include pain in the right hypochondrium that may be colicky or persistent. You may get a positive Murphy sign. Now here I want us to distinguish between two important signs. I want us to distinguish between the Murphy sign and the Moynihan sign. Remember that the Murphy sign, the patient is seated, they take a deep breath, and while you're palpating in the right hypochondrium, the patient winces in pain as they actually reach the summit of inspiration, as the liver has been pushed down to touch the palm of your hand. Then in Moynihan's sign, it's just like the Murphy sign, however, the patient is lying flat. They may have flatulent dyspepsia, they may have intolerance to the fatty meals, they may have biliary dyspepsia. Differential diagnosis includes a peptic ulcer, you may have pancreatitis, you may have a hiatus hernia. Investigations include ultrasound of the abdomen, which may show a stone with posterior acoustic shadowing. You may get the gallbladder wall being thickened. An isotope scan may confirm the infection. A liver function test can be done, as well as a total count that may show a raised white blood cell count. And this is if there is an acute recurrent infection. Treatment includes a cholecystectomy, which can be done through an open method or laparoscopic method, and complications include common bowel duct stones, cholangitis, pancreatitis, and sometimes Meniere's syndrome, where you get this common hepatic duct obstruction that's caused by extrinsic compression from an impacted stone in the cystic duct or in the infundibulum of the gallbladder. Coming back to our warm-up question, we have a 34-year-old woman who presents with mild yellowness of the eyes, pain in the right hypochondrium, and fever. She gives a history of previous episode which resolves on antibiotic treatment. Answer the questions below. So the most likely diagnosis is that she may have an acute cholecystitis. The most likely cause is a gallstones or cholecystitis. The two other things you would ask on the history is the pain with fatty meals and is the pain radiating to the right scapula. Two blood investigations you would ask for bilirubin levels, which are part of liver function test, and alkaline phosphatase. You may also order for serum amylase. The two important signs that may be present on abdominal examination are the Murphy sign and the Moynihan sign. Then, of course, the radiological investigation that is indicated is an ultrasound. Ignore the liver part, it must have been a typo. I really hope you enjoyed this video on cholecystitis. If you did, consider subscribing to the channel. Hit the bell notification icon so you never miss on such amazing content every time I post. Until next time, my name is Dr. Moses Kazevu.